Antimuscarinics, or anticholinergics, are medications that function through the competitive antagonism of the M1 through M5 G protein-coupled receptors. At these specific receptor sites, the primary neurotransmitter being blocked is acetylcholine. By preventing acetylcholine from binding, this localized receptor blockade globally inhibits the body's parasympathetic rest and digest tone across multiple organ systems. Competitive antagonism of muscarinic receptors essentially removes the physiological brake from the autonomic nervous system, triggering profound multi-organ shifts. Patient exposure to these effects is massive. Over 600 common medications carry unintended high-burden antimuscarinic properties. This widespread overlap exists because various G protein-coupled receptors share underlying structural similarities, which drastically reduces drug selectivity. Because of this cross-reactivity, medications designed for entirely different primary purposes still inadvertently bind to and block muscarinic receptors. This chart lists the specific classes of medications most frequently implicated in these unintended effects, with first-generation antihistamines, tricyclic antidepressants, and antipsychotics all categorized as high-burden agents. This lack of receptor selectivity transforms what should be a precise pharmacological tool into a widespread unintended variable in global patient care. Despite the risks of broad exposure, intentional muscarinic antagonism is strictly required in specific clinical settings to stabilize patients and save lives. In cardiovascular medicine, atropine is administered to provide short-term relief for hemodynamically significant bradycardia or AV block. In toxicology, atropine serves as the primary antidote for cholinergic poisoning, such as exposures to organophosphate insecticides or muscarine-containing mushrooms. In respiratory care, ipratropium bromide, a quaternary analog, is delivered via inhalation as a rescue medication to relieve vagal bronchospasm in asthma and COPD. In surgical settings, glycopurolate is used preoperatively as an anti-sialagogue to reduce salivary and respiratory secretions and protect the airway. Glycopurolate also plays a critical intraoperative role. It is administered alongside neostigmine at the end of surgery to block severe muscarinic side effects during the reversal of non-depolarizing skeletal muscle relaxants. When tightly controlled, antimuscarinics are essential tools that resolve life-threatening crises by deliberately disabling targeted parasympathetic pathways. Because muscarinic receptors are distributed systemically, administering high doses triggers a classic multi-system acute toxidrome. This presentation is tracked using a medical mnemonic, starting with blind as a bat, which stems directly from the blockade of parasympathetic innervation to the eye. The medication blocks the iris sphincter, forcing the pupil wide open, called mydriasis. This allows excessive light to enter, causing photophobia. Simultaneously, it paralyzes the ciliary muscle, termed cycloplegia. This prevents the lens from changing shape, destroying accommodation and fixing focus for far vision. An inability to read a restaurant menu perfectly illustrates how a chemical receptor blockade manifests as complete functional paralysis in an end organ. This infographic details the remaining toxidrome. Mad as a hatter signifies CNS delirium. Red as a beet means vasodilation. Hot as hell is hyperthermia from blocked sweat glands. Dry as a bone is acute xerostomia, and full as a flask indicates acute urinary retention. Severe urinary retention requires immediate physical intervention to prevent acute kidney failure, specifically the insertion of a Foley catheter. The acute toxidrome is a predictable, cascading mechanical failure of the entire parasympathetic nervous system that requires immediate clinical stabilization. While healthy young adults typically only exhibit these symptoms at high doses, patients aged 65 and older regularly suffer severe CNS toxicity at normal, standard therapeutic doses. This diagram illustrates the pharmacokinetic shifts that create this vulnerability, starting with the volume of distribution for highly lipophilic tertiary amines. Aging increases total body fat relative to muscle mass. This creates massive storage reservoirs that trap lipophilic drugs and prolong their half-life. At the same time, natural age-related declines in hepatic metabolism and renal function drastically reduce the rate at which the aging body can clear the drug. This diagram also shows the neurological vulnerability. Older adults possess increased blood-brain barrier permeability, allowing these lipophilic drugs to easily flood the central nervous system. Once inside the brain, the drug meets the final pharmacodynamic blow. The aging brain naturally suffers from diminished cholinergic reserves and reduced acetylcholine production. Administering an antimuscarinic to a geriatric patient delivers a double whammy. The aging body traps and accumulates the drug, while the aging brain lacks the baseline neurotransmitters required to fight the blockade. While acute toxicity is an immediate crisis, chronic daily exposure to medications with a high anticholinergic cognitive burden results in permanent consequences. Chronic antagonism of cholinergic receptors directly induces neuronal cell death, specifically destroying the neural pathways connecting the basal forebrain to the hippocampus. This longitudinal data shows the physical imaging results associated with this neuronal death. Long-term users exhibit a significant reduction in total cortical volume and temporal lobe thickness compared to non-users. Internally, this tissue loss correlates directly with structural damage, presenting as significantly enlarged lateral and inferior lateral ventricles. This structural deterioration is physiologically matched by profound cerebral glucose hypometabolism, meaning the brain is losing its functional metabolic capacity. Chronic antimuscarinic use permanently destroys the physical architecture and metabolic capacity of the brain. This structural brain atrophy connects directly to accelerated cognitive decline and severe clinical outcomes. This chart breaks down the data established by Gray and colleagues, identifying a critical exposure threshold, cumulative exposure equating to more than 3 years of daily use, or greater than 1,095 total standardized daily doses. Crossing this threshold results in a 54% higher risk of developing incident Alzheimer's and vascular dementia compared to non-users. This data shows the final mortality metric utilizing the anticholinergic cognitive burden, or ACB scale. According to findings by Fox and colleagues, every single 1-point increase in a patient's ACB score correlates with a 26% increase in all-cause mortality. What begins as the competitive antagonism of a single G-protein-coupled receptor ultimately scales into a massive, highly preventable driver of neurodegeneration and death in the aging population.